Hi, my name is Karen Zamaski. I'm one of the Pediatric Hem-Onc Fellows at Emory University, and today we're going to be talking about von Willebrand disease. Starting with our objectives, number one is to list two roles that von Willebrand's factor plays in hemostasis. Two, to differentiate between the three main types of von Willebrand's disease, specifically with regards to the underlying defect, as well as the expected bleeding severity. Three, to recognize abnormal bleeding patterns that should raise concern for possible underlying von Willebrand's disease. And four, to cite two reasons why a high level of suspicion is needed to diagnose von Willebrand's disease in children. Von Willebrand's disease is the most common inherited bleeding disorder. It affects 1 to 2% of the population and is caused by either not having enough von Willebrand's factor or having von Willebrand's factor that is deficient. Von Willebrand's disease was first described in the early 1920s by a Finnish physician, Dr. Erik von Willebrand, who labeled it pseudohemophilia. Dr. von Willebrand studied a total of 58 patients spread across two families who all lived in a set of islands off the coast of Finland. He found that males and females were equally affected with this bleeding disorder and that their lab studies showed prolonged bleeding times, sometimes mild anemia or thrombocytopenia, but otherwise normal clotting studies. He ultimately concluded that pseudohemophilia was due to both platelet dysfunction as well as a defect in vessel walls. It's pretty remarkable given what we know about how von Willebrand's factor functions in hemostasis. Von Willebrand's factor primarily helps to form the platelet plug and also has a role in stabilizing factor VIII in circulation. So starting with the site of endothelial cell injury, von Willebrand factor binds to collagen on the subendothelial matrix. This binding attracts platelets, which bind to von Willebrand's factor. Once platelets start binding, they recruit more platelets, resulting in platelet aggregation or platelet party. This platelet-to-platelet interaction is facilitated by von Willebrand's factor binding. And then finally, fibrin binds to your platelet to help stabilize your platelet plug. Factor VIII circulates in plasma bound to von Willebrand's factor. This binding extends the half-life from approximately 20 minutes to 8 to 12 hours. There are three main types of von Willebrand's disease. Type 1 results from a partial deficiency of von Willebrand's factor. It is the most common type, affecting 70 to 80% of cases. It's inherited primarily autosomal dominant, however, it does exhibit incomplete penetrance and variable expression, which make it less straightforward. And it usually results in mild bleeding symptoms, primarily mucosal and surgical bleeding. Type 3 is the complete opposite, so it's due to complete absence of von Willebrand's factor. It's inherited autosomal recessively and results in severe bleeding, sometimes causing spontaneous joint bleeds and GI bleeding. And type 2 is kind of the in-betweener. So type 2 is due to dysfunctional von Willebrand's factor. It can be further divided into 4 subtypes, which are beyond the scope of today's talk. It can be inherited either recessively or dominantly, and its severity varies, but in general it tends to be more severe than type 1. The bleeding symptoms associated with von Willebrand's disease are primarily mucosal or postoperative bleeding. So you want to look for epistaxis, especially if it's severe, so lasting longer than 10 minutes or associated with large clots or recurrent, and particularly if recurrent epistaxis occurs in young adults or teenagers who are less likely to have recurrent nosebleeds than our toddlers. You also want to look for easy bruising or bruising located in unusual locations, so the back of the legs, the trunk, the abdomen, the back, or the shoulders. You're going to look for gingival bleeding or bleeding with dental extractions, especially if they needed intervention. And you want to look for post-operative bleeding, specifically with regards to minor elective procedures. So your larger procedures that are often associated with inflammation, such as appendectomy, are associated with lots of stress. Von Willebrand's factor is an acute phase reactant, so in the setting of lots of stress, your levels increase and you're less likely to have bleeding. Other significant bleeding symptoms include that of menorrhagia and postpartum bleeding. With menorrhagia, I think it's very important to understand how to take a good menstrual history. This pictorial bleeding assessment chart has been used to help diagnose menorrhagia and has a relatively good specificity and sensitivity for this diagnosis. So you want to have your patient record the number of pads per day or tampons per day based on how soaked they appear, and also to keep track of the number of both small and large clots. And then ultimately you'll give them a score. And menorrhagia is likely if your bleeding assessment score is greater than equal to 100, or if they're reporting grape-sized clots, then needing to change pads or tampons more than once an hour, or a low ferritin level. Well, knowing how to take a good bleeding history and understanding what makes up abnormal bleeding is important. Many children lack hemostatic challenges, so they'll have a negative bleeding history. And this negative bleeding history does not rule out von Willebrand's disease. So when you're worried that a patient might have von Willebrand's disease or another inherited bleeding disorder, you want to start with some basic screening labs. You want to do a CBC to look for anemia and thrombocytopenia. As Dr. von Willebrand noted, you can have mild thrombocytopenia, specifically with some of the type 2 subtypes of von Willebrand's disease. You want to look at your PT and your PTT. Your PTT can be prolonged with von Willebrand's disease, although it's most likely to be normal. You want to send a type and screen, namely because your von Willebrand's antigen levels will vary with your blood type. And then you want to send what's called a von Willebrand's profile. And this includes an assessment of your von Willebrand's factor antigen levels, as well as your von Willebrand's factor activity, which is measured with what's called a ristocetin cofactor activity, and then also a factor VIII level. Based on your von Willebrand's profile results, you can determine what type of von Willebrand's disease is expected. So with type 1, you'll have a mild decrease in von Willebrand's factor antigen and ristocetin. Your factor VIII level may be decreased or normal. The most important thing is that your antigen and risto decreases are proportional. In type 2, you'll have a marked increase in your ristocetin cofactor activity, more so than compared to your antigen level. And again, your VIII level can be normal or decreased. And remember, with this type, you'll have to do additional testing to determine which subtype of von Willebrand's disease the patient has. With type 3, your von Willebrand's antigen and risto levels are generally undetectable, and your factor VIII level is in the range of less than 6%, so markedly decreased. Remember, von Willebrand's factor is an acute phase reactant, and many factors can increase your von Willebrand's factor levels. So if you have a patient who you highly suspect might have von Willebrand's disease, but their von Willebrand's profile testing is normal, you likely will need to repeat that testing at a different time. Overall treatment is reserved for active bleeding or prophylaxis for surgical procedures. There are 4 main options. DDAVP or desmopressin is the most commonly used. DDAVP promotes the release of von Willebrand's factor from endothelial cells where it is stored. You have to do what's called a STIM test to see if the patient will respond to DDAVP. DDAVP is contraindicated in certain subtypes of type 2 von Willebrand's disease, as well as in other settings. You need to be aware of the side effect of hyponatremia and instruct patients to restrict their water for the next 24 hours. As adjunctive therapy, you can use antifibrinolytics, which help stabilize your platelet plug. These are namely Amicar or Lystida. They also have the added benefit of being able to work topically. However, they're contraindicated in the setting of hematuria. Humate P is your go-to when your desmopressin is not available or is contraindicated. It is a plasma-derived factor VIII and von Willebrand's factor concentrate. In a pinch, cryoprecipitate will work as it contains both von Willebrand's factor and factor VIII concentrate. However, this is generally reserved for life-threatening bleeds and only if von Willebrand's factor concentrate is not available. Our take-home points today are that von Willebrand's disease is the most common inherited bleeding disorder, that von Willebrand's factor helps form the primary platelet plug and also stabilizes factor VIII in circulation. There are three main types of von Willebrand's disease. Type 1 is a partial deficiency of von Willebrand's factor, and it results in mild bleeding. Type 2 is dysfunctional von Willebrand's factor protein and results in variable bleeding. Type 3 is complete absence of von Willebrand's factor, and it results in severe bleeding. Your bleeding symptoms in von Willebrand's disease are primarily mucosal, menstrual, and postoperative bleeding. And a high level of suspicion for von Willebrand's disease is needed in pediatrics, namely because patients will normally have a negative bleeding history due to lack of hemostatic challenge, and also because von Willebrand's factor is an acute phase reactant and your screening labs may appear normal. I want to thank you guys for taking time to listen to today's talk. Please let me know if you have any questions or concerns. Thanks.